and welcome to the MedWire News podcast. In this edition, we're talking to medical sociologist Ashby Walker from the University of Florida in Gainesville about the All-for-One peer mentoring program, which pairs teenagers with type 1 diabetes with college student mentors who also have type 1 diabetes. The pilot phase, the results of which have just been published, focused on teens with low socioeconomic status who represent a vulnerable group at particularly high risk of poor outcomes in both the short and the long term. The student and teen pairs had weekly text message exchanges, attended the teenagers' clinic appointments together, and attended social events with the other programme participants and their families. Ashby Walker explains how the programme came about.
So the All-for-One program really culminated after years of some preliminary work that I did as a sociologist with my colleagues who are pediatric endocrinologists. So it was a multidisciplinary effort. And we were able to show that affluent teenagers with type 1 had a lot more in terms of social support systems for their disease when we compared them with lower income, working poor teenagers and children. So this program was developed to try to offset those differences in social support and to add another layer for, families and children who really need additional support when it comes to managing a chronic disease. I think that this intervention represents one additional layer of social support that we can give communities living with type 1 diabetes. This is not a medical intervention. We were not offering any new technologies or devices, which I do think would even further, increase the success of a program like this. But I think it demonstrates the power of people and how they can be powerful agents for each other. And something that someone living with type 1 diabetes has to offer somebody else living with type 1 diabetes is not something we can give them as medical professionals, but something that's really powerful and shouldn't be overlooked as an intervention.
One thing I noticed in your results was that it had a great effect on the student mentors. They were describing it as life-changing and stuff. Were you expecting it to have such an effect on them as well as the teens?
We definitely felt like it was going to be beneficial for the college students. Even affluent college students, there's research that shows when they transition from young adulthood to independent living, it's hard to manage this disease. So we expected that it would be beneficial. To the college students, I don't think we knew how great that benefit would be. So getting them together in this very intimate experience with 21 other college students on a very large university campus. I mean, we have over 50,000 students on our campus. So to bring together college students who all live with this chronic disease and give them those networks themselves ended up being, I would say, equally beneficial for the college students. I mean, it was designed as an intervention for the teens, but I really believe, and my colleagues feel firmly, that this is a two-sided intervention, that this really is as much about the college students as it is the teenagers.
You said that in the paper that you find it easier to recruit female than male mentors. Is it actually an issue for you, recruiting male mentors?
It is an ongoing issue for any social scientist, and there's research that shows that females are more likely to participate in survey research. That this is not just specific to this particular project. However, it made me very sad because I know the male adolescents need this just as much as the female adolescents, as do the college students. So I do think, even now when we're doing this again, there's far more females than males participating. And it limits my ability to enroll male adolescents when I don't have enough male college students. And we've talked about it as a group, and I've asked the college students, why do you think that more females respond? And they think it's a lot just about gender and females being more willing to be open about the need for social support, and maybe it being harder for males to kind of acknowledge that. But I've really appreciated the males we've had in the program, and we really probably should, as researchers, strategically think about how to increase enrollment of our males, because we know gender rates are equal in type 1 diabetes. This doesn't impact, type 1 doesn't impact females more than males. So there's theoretically, statistically, we should be able to get equal rates of male and female participation.
I realise this was obviously a pilot, but if you'd been designing it as a powered study, what do you think your primary outcomes would have been? Would it have been the glycemic control, or would it have been the more kind of, the more social outcomes?
I think when we designed it, so much research in type 1 diabetes and type 2 diabetes focuses on improving glycemic control. And while we recognize that that is such an important outcome, and we included that as a primary outcome, I think looking back, we're so glad that we included the Children's Hope Scale that really is measuring a child and teenager's hope for the future, and it also measures their confidence that they're going to be able to be an agent of change in their own future. And if you look at those changes over time, they were profound. And to give a child or a teenager a more hopeful glimpse of their own future, that's something that is I can't say it's more important than glycemic control, but I think over the long term, that improving their hope and their confidence in the future could have subsequent improvement in A1C and their ability to manage their disease. So I really believe for a pilot like this, the Children's Hope Scale is as important of a finding as glycemic control would be.
The success of the pilot led to the expansion of the programme as a quality improvement project. It now enrolls teenagers regardless of their socioeconomic status. During the pilot phase, which was funded by the Helmsley Trust, mentors were paid a stipend of $500 for their participation. This is no longer possible in the quality improvement phase, but doesn't seem to have dented the mentors' enthusiasm for the project. Recruitment has not been an issue. Nevertheless, the programme still has associated costs, and how do you judge the cost effectiveness of something based to a large part on psychosocial outcomes?
I think I would need a good health economist on board to help me answer that, and I am a medical sociologist, so yeah. I think it's hard to calculate the impact of something like this, because we could certainly look at, did we keep these teenagers out of the hospital for DKA? Did we reduce hospitalizations for DKA for a group of kids that are really at risk? But I think that the measurement would have to go long term into the future to really understand the ripple effect of something like this. How do we really calculate for a college student? I can tell you I've received letters from a parent of a college student and from college students who say, I really was thinking about transferring colleges to be closer to my family, but this program helped me feel integrated into the college campus and connected with people, and I want to stay. So I don't know how we fully measure impact. I think if we roll this out on a bigger level and we have collaboration, whether it's just collaboration within the United States or even internationally, we could think really big.
Yeah.
We could measure outcomes by reducing the most serious complications in the short term of living with diabetes, but I think there would need to be longitudinal data that showed what having social network support does for somebody across a longer period of time.